Hello, I am Yonatan Grad. I'm an assistant professor of immunology and infectious diseases at the Harvard Chan School of Public Health and an associate physician in the Division of Infectious Diseases at Brigham and Women's Hospital, Harvard Medical School. Today, I will talk about some of our work using modeling and other approaches to understand social distancing and COVID-19 and give a sense of our projections as to where we are headed. To begin, I will refer to a piece that my colleague and friend Mark Lipsitch and I wrote about a month ago. At the time, when we were just starting with social distancing and just starting to flatten the curve, to use a phrase that I suspect many are now familiar with, we described how we were just really clambering into a life raft and that dry land is far away. And what we were referring to is the idea that even though we were responding in a robust fashion to the pandemic, there is quite an amount of time between those responses and really how, or the timing of the ending of the pandemic, that we're just in the first phases of the response. So I want to provide a framework for thinking about how the pandemic ends. There are two possible ways. I'll start with the second one. We could eliminate the virus. This is what happened with the 2003 episode with SARS. There, an incredibly strong, robust public health response led to control of SARS and eventually its elimination. The other possibility is population immunity. Now, with the elimination of the virus, I think it's now with the virus spread all around the world, I think the second possibility is extremely unlikely. And instead, we're really looking at this first one of population immunity. By population immunity, I mean that enough of the population has to be immune such that we see the end of spread. When does that happen? Well, that has to do with how transmissible the virus is. This gets to another term that I think has been a fair bit in the news recently, and this is the R0, or the basic reproductive number. It's in essence the transmissibility of the virus. For SARS-CoV-2, we think that number is around 3. So what does that mean? Basically that we need to have 2 out of 3 people already immune in order to see that transmission chains will start to slow down. So the R0, this value of 3, means that on average, an infectious person will infect 3 other people. We need to get that, again, below 1 in order to see the end of the pandemic. And so that means more than 2/3 of the population needs to be immune. How can that happen? Well, if infection and recovery then confer protective immunity, one way is to have around 2/3 of the population infected. The other way is for people to get immunity from a vaccine. Right? So if we find an effective vaccine and give it to enough people to achieve over this 66–67%, then we can see population immunity. So this is really kind of the mindset that we need to have to understand what our options are. This figure comes from Debbie Birx and the White House Task Force. And it's, again, one very familiar with people, and it helps to shape, again, our understanding of the options that we're facing. So how can we get to this herd immunity? One option is to just let the epidemic go, and we see that this will cause a large number of deaths. That's both because of the unmitigated epidemic, but also because when we have this huge strain on the healthcare infrastructure, we expect that it will potentially lead to the collapse of that infrastructure, and that not only would people die from COVID-19, but also the inability to get care for heart attacks, strokes, and other medical conditions that they would normally be treated for. And then as well, there would be huge economic impact to the collapse of the healthcare system. So what we're trying to do is, as demonstrated by this lower curve, is to flatten the curve, right? And the idea here is that it will help maintain the the healthcare infrastructure, that by slowing the rate with which people are getting infected, by engaging in social distancing and trying to slow the spread of the virus, we will not overwhelm the hospitals and other healthcare institutions. And that it will also give us time, we hope, for the development of other interventions, effective medications, vaccine, and so on, that together will help slow the impact and lessen the impact of the virus. So knowing that we're not going to be able to eliminate the virus, and that we're really looking at this an end game where we have population immunity, there are three possible paths we can take. The first is to stop the social distancing that we've started and just let the epidemic go. The second is to try social distancing to flatten the curve and kind of achieve this balance that I was talking about before, of not having so many cases that we overwhelm our healthcare infrastructure, but also we're not kind of towards the end of trying to reduce spread entirely. That is the third option, that we combine social distancing with case identification, contact tracing, isolation, and quarantine, and try to not just flatten the curve, but crush it. And this basically means that we'll try to prevent all cases and maintain the population as susceptible, so that a large fraction of people will still be susceptible to infection. And then we wait for a vaccine, because again, we need to figure out some way to get up to this level of herd immunity. The first option is bad. In fact, all of them are bad, but some are clearly worse than others. So letting it go is a bad option. Here we have data from Wuhan. So Wuhan shut the city down when they had 500 confirmed cases in a population of around 10 million, which is about the size of New York City, a little bit larger. And they reached a per capita demand for ICU beds equal to fully occupying the ICUs available in the US just for COVID-19, so absent all other medical conditions. And it took about 4 weeks from this shutdown to peak ICU need. And so that gives you a sense of the delay between taking action and the amount of spread that has already happened and the time it takes for people to then present to hospitals and critical care units. So we know this is a bad option. We've seen it in Wuhan, we've seen it in northern Italy, we've seen it in New York, right? The amount of devastation that can happen in the absence of intervention, or even if interventions are delayed. So this leads to a question: if we are continuing on with social distancing, how long will it last? This is particularly operative now when we're seeing different states and different places around the world start to lift their social distancing interventions. So what's going to be the impact of stopping social distancing at different time points? So this is something that we investigated in a paper that was published a few weeks ago in Science. And I'll take you through some of the results in this paper. So one of the first things we were interested in is whether there is seasonality. So this is a question that has arisen from the first observations of COVID-19. Do we expect that there is augmented spread in the winter and diminished spread in the summer, like we see with other respiratory viruses such as influenza? To ask this question, we thought we would look at other human coronaviruses, particularly the 2 beta coronaviruses that already circulate in human populations, HKU1 and OC43. And we used data from surveillance systems in the United States to get a sense of the extent of seasonality. And we can see that in these plots here. And sure enough, for these other beta coronaviruses, the ones that are, again, closest in circulation to SARS-CoV-2, we can see that there is seasonality. So this then became the model for which we could ask about SARS-CoV-2 seasonality. Again, we don't know for sure whether there is seasonality, but this at least gives us a benchmark that we can use when exploring what might happen and starting to make projections about possibilities going forward. So here we look using a standard epidemiological model that models infectious disease dynamics, what might happen under various scenarios. So in the black line, we have no intervention. In the red line, we have modestly successful social distancing. In blue, more successful social distancing. And in green, social distancing that was as successful as what was seen in Wuhan. So very aggressive lockdown. The dotted lines reflect the critical cases, the incidence of critical cases and again, you'll see them delayed by a little bit. This goes back to the observation from Wuhan that it takes a few weeks from your peak of cases to then see the peak demand in the critical care units. Here, the purple boxes reflect the duration of social distancing interventions. So we have social distancing of 4 weeks, 8 weeks, 12 weeks, 20 weeks, and indefinite. The main point to make here is that as we have social distancing that is varyingly successful, the extent to which it is successful helps determine what will happen afterwards. So if it is very successful, as in the green lines, what we'll see is very few people infected during the social distancing effort, but those people remain, the rest of the population remains susceptible. And so we will see, once we stop social distancing, again, the rise of a resurgence in infections. So to the extent that we're successful in maintaining a susceptible population by diminishing spread, once we stop our social distancing efforts, we'll see peaks arise again. Now they're smaller than the original peaks, but nonetheless, we will see a resurgence once we stop. That was in the absence of seasonality. Now, what if there is seasonality? Again, diminished spread in the summer and increased spread or augmented spread in the fall and winter. But here, our social distancing efforts at this time of year, at least in the Northern Hemisphere, are augmented themselves by the diminished spread, meaning we are more successful in our social distancing efforts over the summer. But once we get to the fall and winter, the increased spread associated with seasonality, the increased transmissibility of the virus associated with seasonality will lead to even bigger peaks in the fall and winter. So in the absence of seasonality, we'll still see, we'll see a resurgence. And in the presence of seasonality, we'll see even bigger resurgence in the fall and winter. So to summarize, for one-time social distancing interventions, if seasonality is negligible, then all social distancing helps, and long, moderate social distancing is best. If seasonality is present, then long, weekly effective social distancing is best, but strongly effective social distancing can actually make things worse by delaying the peak into the winter. And again, we'll see both increased transmission, but also at that point, it will coincide with the influenza season, which already stresses the healthcare infrastructure, and I think will lead to even greater problems. So we suspect that there will be some seasonality, so our one-time interventions could actually make things worse in the absence of other interventions. Now, since we responded to starting to see the first peak with social distancing, we wondered, well, if we're going to stop social distancing and then start to see another peak, maybe we'll start social distancing again. And this leads to a notion of cycled or intermittent social distancing. There are many different ways to envision how this might take place. Here we just present one of them, which is perhaps the simplest and most optimistic of a very aggressive social distancing. And this is in the absence of other types of interventions. So this is not including contact tracing, not including new medications, or other types of interventions that themselves might have an impact. This is really just thinking about cycled social distancing alone. And so when would we start social distancing? Well, we'd start it when we set some kind of thresholds that we would predict would threaten the healthcare infrastructure, right? Again, that is the balance that we're trying to strike here. And we would need to keep on doing this with on when we know we're heading towards this threshold for critical care cases, and turn it off as we're coming down, and then on again and off, a kind of thermostat model. And doing this repeatedly until we start to approach herd immunity. But this kind of approach without seasonality is, and given our current ICU capacity, would take quite a long time into 2022. Seasonality helps us a little bit because we'd have longer periods in the summer because there'd be decreased transmission, but it would still take quite a long time. Now, if we were to double our ICU capacity, it gives a little bit more breathing room, so to speak. And having new medications mathematically basically is the same thing as increasing capacity, because it slows or it reduces the number of people who enter into the hospital and from the hospital into critical care beds. So it can function basically similarly. And having increased ICU capacity basically allows us to spend more time and that will get us to herd immunity faster. And then again, with seasonality, that can help accelerate this as well, so that we could have fewer rounds of this type of distancing. So if there's no seasonality, then we would have, with intermittent distancing, a slow accumulation of herd immunity. Seasonality is helpful in this scenario, and that longer time off due to summer slowdown will be helpful. And then increasing our ICU capacity or other types of interventions could allow for longer breaks and faster accumulation of herd immunity. This, however, really requires having good surveillance. Again, it was the decisions to turn on and off social distancing are in this case really tied to being able to carefully track the number of cases and hospital capacity. And of course, this is something that requires intense political and social will. And there are, as with all interactions with diminishing interactions, all lockdowns, it has big economic consequences. And so it will really require some careful thought and strategizing. Now, the third option that I mentioned is to combine that social distancing with contact tracing and quarantine to try to crush the curve and prevent all transmission. And in this paper, which is now in press in Lancet Infectious Diseases, we looked at the type of interaction, or what happens when you combine social distancing and contact tracing, quarantine and isolation, and we're able to show that they synergize. But what I really want to underscore is that contact tracing is not itself the intervention. The intervention is then quarantine or isolation. Quarantine for their contacts and isolation for those who are known to be infected. And that also requires intense support of the population in order to try to make that intervention actually happen. So in this third option, let's say we're actually successful. We flatten the curve or crush the curve with aggressive case finding, contact tracing, isolation, and quarantine, and really try to prevent all ongoing transmission. So the problem here is that the extent to which we're successful, unless there's a lot more spread than we're aware of, and many, many asymptomatic individuals who have been infected and recovered without our knowing about it, if there's a substantial fraction of the population that remains susceptible, we will need to continue to have these interventions in place until we get a vaccine. And those interventions are going to be remarkably restrictive and could include monitoring all travelers or even restricting domestic and international travel. Because again, there will be some places in the world that choose option one, other places that choose option two, where we'll see the virus continuing to transmit. And we'd have to prevent those individuals who are carrying the virus, even carrying it asymptomatically, from getting in and starting epidemics again. Singapore, with arguably the world's best public health system, system already trained by the first round of SARS and worried about a variety of other types of respiratory outbreaks, has tried this approach. So they have very aggressive contact tracing, isolation and quarantine. And even Singapore has had resurgence, has had little flare-ups that led to a 4-week lockdown. So this kind of approach will require remarkable vigilance. And then even in this approach, we should expect to see at least some cases flare up, and the possibility of having to institute additional social distancing measures on top of these. So what do we do now? This slide I originally wrote around 1 month ago at the beginning of April, and here we are at the beginning of May, and I think many of these principles and needs still apply. We need to build capacity to control transmission by continued social distancing. We still have a massive deficit in testing. We need to get that ramped up. And we need to meet the needs of healthcare workers for personal protective equipment. We still don't have enough PPE. We need to invest in efforts to mitigate the impact of COVID-19 by rapidly finding treatments. There's been some advance with remdesivir, but we need more. We need treatments that are oral, that can be given outside of the hospital, and that are effective and potentially even are prophylactic. We need to increase our healthcare capacity. We've seen many hospitals convert even operating room ventilators into ones that they can use in intensive care units. And we may need to really bolster that capacity as we anticipate future resurgence. And we need to really accelerate the work on a vaccine, because again, it's only that combination of either immunity from infection or immunity from a vaccine that will bring us to the end of the pandemic. One of the types of testing that we'll need is serological testing. Because we didn't have the diagnostic testing that would really allow us to track the epidemic from the beginning and get a sense of how many people are infected and where and how it's spreading, we now need to use serologic diagnostics that tell us about people who have had past infections to understand where the disease has been and how it has spread. And there are multiple challenges to designing and interpreting both prevalence and seroprevalence surveys, but we and many others are trying to develop these types of surveillance studies. Having thought hard about what these studies should entail, and the challenges involved in developing them, we developed a statistical framework to help with seroprevalence analysis, forecasting, and study design. This is available on medRxiv, so you can find it online. And it helps with both convenience and formal sample schemes. So you can go from newborn blood spots or US blood donors or other types of survey designs to inferences about seroprevalence in populations, and then to develop the epidemiological parameters that can inform modeling and policy decisions. And we have a website where we have calculators that can help with this as well. So with that, I'd like to acknowledge all of my collaborators and the citations of the papers that I've mentioned over the course of this talk. You can find more information in each of these papers. Thank you so much for your attention, and have a good evening.